Bismillahirrahmanirrahim. First of all, I would like you all to be I would like to welcome to this presentation. This topic today is very dear to my heart for two reasons. One, my own interest in the cardiology, and because this is something which presents to the emergency department so often and every day that if we are not at 100%, there is every likelihood that the patient will suffer and will miss myocardial infarction. Since our early days, we have been taught about the classical symptoms of chest pain, whereby you are told that it is central chest pain around to the left side, going into the arm and going into the jaw, with diaphoresis and sweating. So this is the classical bookish picture of a chest pain. And from my own experience, and I'm sure the experience from all of you, you would have seen that we are seeing these kind of patients less and less. So I wanted to bring this up today for two reasons. The reason was that we wanted to make sure that how we can try not to miss these cases, and also going forward, how we can improve ourselves. So I'm going to start with two case reports where you would see that they are not the classical cases. So the first one is a 70-year-old male, presents with history of intermittent chest pain for 2 days. The first episode was on a Saturday night, which lasted all night, and the pain score was 2 to 10. No pain during the day and did not affect the normal activities. Then he had again pain on Sunday night, no radiation, and attended ED at 6 p.m. He related that this pain was due to ingestion of a meal on Friday, and he thought it was indigestion. In the past history, he had his right total hip replacement and knee replacement. He had done twice, and he was non-smoker, non-diabetic or hypertensive and ischemic heart disease. Examination were unremarkable. His ECG was showing right ventral branch blood with Q waves in 3 AVFT, depression, V1 AVR. His bloods were sent and seen by myself, and we asked for cardiology to review him, regardless of the troponin results. He was seen by the cardiology and admitted for serial data. His first troponin was hemolyzed, and the second troponin was 0.4, obviously, which was raised. So an angiogram was done, and he had a stenting to the FRCEM. The second case is only about a couple of weeks ago. It's a 27 years old hospital employee, known case of acid peptic disease, and had this pain for the last multiple times, and had seen gastroenterologists for this as well, and was on treatment. I presented with epigastric pain since early morning and attributed this pain to the food last night. Not willing to get ECG or bloods done simply because he said that he gets this pain all the time, and he was not willing to do these tests. ECG initially was refused, but our staff and I commend them that they kept on persuading him and insisting that they need to do an ECG because that's the guideline and policy that any epigastric pain has to have an ECG. So an ECG was done, and which showed an inferior wall MI, and his troponin was also raised, and he got stenting to his LT. So these are the two cases, classical cases, which represent that atypical thing which I'm trying to bring up. So the low-risk patient with chest pain, how much evaluation is enough in ED? So that's the question we always ask ourselves, that for what is the max I can do before I hand over to the cardiologist? And we all dread that if we miss an MI, that has a devastating effect, not on the patient, relatives, and the doctor itself. Many patients with chest pain and other symptoms consistent with ACS do not have the diagnosis. So how exactly these patients should be evaluated to exclude this diagnosis? So this is an atypical stuff from a study in New England Journal of Medicine. There were 6,000 patients. The chest pain greater than 48 hours. There were new ST changes in 20% of the cases. There were no new ST changes in 1%. The pain was reproduced by palpation in 1% of patients. The stabbing pain was 3%. 2% were less than 40. And the pain radiation to the back, legs, and abdomen was 1%. So there is a study about the ACS without chest pain. This is a global registry study, GRACE, 14 countries, 95 hospitals, more than 20,000 patients with suspected ACS. 8.4% had no chest pain. So this is a very high number. Only atypical symptoms of dyspnea, diaphoresis, nausea and vomiting, and syncope. So you can see that about 8.4% of the patients doesn't have the classical symptoms. 1/4 of the patients without chest pain did not have ACS initially suspected. The mortality is much higher if no chest pain, 13% versus 4.3% in patients who have chest pain. It simply tells us that because there is delay in diagnosis, we don't think about ACS in patients who doesn't have chest pain. And that's the point today, that we need to think about other symptoms like dyspnea, diaphoresis, nausea, vomiting, syncope, that these patients can also have ACS. Elderly is a population which is very prone to these things, and there's a study in Geriatrics Journal. There were 777 acute myocardial infarctions, ages between 65 to 100. Chest pain was only seen in 66%. So this is the age group which we need to be very careful when they present to the emergency. I see them anyway. That only 66% would present with chest pain, and the frequency of chest pain decreases with age. 75% at age 70 and 50% at age 80. Chest pain is infrequent above the age of 85, and we need to be aware of these atypical symptoms in elderly. Advancing age will give you less and less classical symptoms. The typical symptoms of acute myocardial infarction in elderly, also from the same study, said that the 40% would present with dyspnea, 14% with syncope. There will be unexplained weakness in 7% of the cases. They might feel giddiness, and some people may have stroke as well. So if you take one message from today is that be aware of dyspnea in elderly. Do not disregard it, even if they have no chest pain. This is most likely because of an MI. So coming to the ED again, do risk factors actually help in ED when we are assessing our patient? The risk factors alone rarely are helpful in the ED. Men, diabetics, family history increases the probability. In women, no, we don't. But these are the two factors, male and diabetic with the family history. It does increase the probability of heart disease. So we do an ECG, and misreads are the single most biggest cause of missing an acute myocardial infarction. So I suggest to all our juniors that whenever they have any doubt about the ECG, they must ask somebody else. Do not assume things that it could be right because the patient doesn't have chest pain. And what I'm seeing, maybe it's an artifact. So if you feel that this is the case, always repeat an ECG. And in fact, any patient presenting with cardiac sounding chest pain should have an ECG repeat. The initial ECG should be done within 10 minutes of arrival and another ECG within 10 to 20 minutes. We need to look at the value of extra leads. The 12-lead ECG may miss right ventricular and posterior acute myocardial infarctions. So the right-sided is V4, V5, V6 lead may help in diagnosing the right ventricular myocardial infarction. And posterior leads V7, V8, and V9 help in diagnosing the posterior myocardial infarction. So what is the significance of posterior myocardial infarction? The posterior infarction accompanies 15 to 20 patients of the STEMIs and usually occurring in the context of an inferior or lateral infarction. Isolated posterior MI is less common, 3 to 11% of infarcts. The posterior extension of an inferior or lateral infarct implies a much larger area of myocardial damage with an increased risk of left ventricular dysfunction and death. Isolated posterior infarction is an indication for emergent coronary perfusion. However, the lack of obvious ST elevation in this condition means that the diagnosis is often missed. Be vigilant for evidence of posterior MI in any patient with an inferior or lateral STEMI. So how do we actually spot the posterior infarction? So posterior MI is suggested by the following changes in V1 to V3. Horizontal ST depression, tall broad R waves, upright T waves. In patients presenting with ischemic symptoms, horizontal ST depression in the anterior septal leads should raise the suspicion of a posterior MI. Posterior infarction is confirmed by the presence of ST elevation and Q waves in the posterior leads B7 to B9. You can see that here, B4, B5, B6, and then they are placed posteriorly, and that's how you get a posterior lead. Right-sided MI, you need to look and suspect for right ventricular infarction in all patients with inferior STEMI. The clinical significance of the right infarction is that right ventricular infarction complicates up to 40% of the inferior STEMIs. Isolated right ventricular infarction is extremely uncommon. These patients are very preload sensitive due to poor right ventricular contractility and can develop severe hypertension in response to nitrates or other preload reducing agents. So patient with right ventricular infarct needs fluids, and we need to avoid nitrates in these patients. So how do you spot a right infarction? In patients with inferior STEMI, right ventricular infarction is suggested by ST elevation in V1, ST elevation in V1 and ST depression in V2, highly specific for right ventricular infarction, and ST elevation in 3 is more than in 2, V2 limb lead 2. So diagnosis is confirmed by the presence of ST elevation in the right-sided leads V3R to V6R, which you can see can be placed on this side, right side of the heart. So we always assume that if there is any change in the ECG, that it will only mean that patient has an MI. There are a few studies which showed that that is not the case always. A study in JAMA by Welsh, about 73,000 patients, 4.4% of the patients had an acute myocardial infarction, but the ECG was normal. And similarly, you can see the incidence is about 3% in another study, 2% in another study, and Bihar, it was 5%. So the message is that ECG could be normal, but patient may have an MI. And how do we diagnose these patients? I mean, that is the clinical thing we need to do. If the patient is having continuing chest pain and you have seen that ECG is fine, the Trop is fine, but the chest pain is still there, these patients cannot be discharged. They have to be admitted and observed further. Just because their ECG is fine doesn't mean that they don't have an AMI. There is another misconception about giving GTN and thinking that if the patient gets the relief by GTN means that he has an ACS. So there's a study in International Journal of Medicine which says that GTN does not predict ACS. The study about 459 admitted patients in ED with chest pain, 35% ACS patients responded, 41% non-ACS patients had pain relief as well. So the data strongly suggests that the response of chest pain to nitroglycerin, although therapeutically beneficial, has little diagnostic or prognostic value. This is another study about 100 proven missed acute myocardial infarctions autopsy study. They identified 4 key factors, which I have alluded to earlier as well. To summarize them here is that there was unjustified dependence on misleading lab. The patient may have had chest pain, but the drop became normal, and we said, no, he can't have an MI because the drop is normal. There was inattention to suggestive lab studies. There may have been very small rise in some of the tests or early rise in a drop, which was overlooked. Atypical presentations was another major cause of missed acute myocardial infarction. And I have alluded to them, especially in the old age dyspnea, weakness, giddiness, syncopal attacks. These are all kind of things which we need to be aware of. And the last thing they found was that it was a failure to consider acute myocardial infarction as a possible diagnosis. And that was because of the atypical presentations, maybe because of the normal ECG, maybe because the patient did have some other complaints. So these are the 4 key factors which we all need to keep ourselves aware of, that they can lead to a catastrophe if we don't pay attention. Now we come to the diagnosis of chest pain, myocardial infarction in emergency department, and how we can actually filter these patients and discharge all of them or some of them at home. We rely on biochemical tests, and creatine kinase has 3 isoforms. Muscle, 70 to 85% of the total. CK-MB is brain and bowel, and MB is the cardiac. Timeline for CK-MB enzyme rise is 4 to 8 hours at the earliest rise, and 12 to 24 hours peaks and returns to normal in 2 to 4 days. So CK was used in collaboration with troponins early on, but now it has fallen out of favor just because it is only detected after almost about 4 hours of episode of chest pain. So it's very helpful in terms of patients who present to the emergency. The next test we all know about is troponin test. It's a regulatory protein of the myofibril. There are 3 types of troponins. Troponin C binds calcium, Trop-T which binds troponins and myosin, and Trop-I is an inhibitor. Troponin in acute myocardial infarction, it's very unreliable, I would say less sensitive in the early part of the chest pain. It's very sensitive in the later part of the chest pain. So it's 50% sensitive at 3 to 6 hours and 100% sensitive at 10 to 16 hours. And it lasts for about 7 to 10 days. A single negative troponin does not exclude acute myocardial infarction. That's why we always say that troponin done earlier than 6 hours is unreliable, and we may miss a myocardial infarction. So there is a need for a test which actually tells us something better before that 3 to 6 hours window. This is a study about how accurate is one CK-MB Or Troponin to rule out an ACS. It was 22 years of meta-analysis, and single test will miss 51 to 63% of the cases. Acute sampling of the new onset symptoms yields worse results for predicting MI. So as I said, the troponin and the CK-MB usually don't rise between 3 to 6 hours. So anything, if we sample somebody at 2 hours, we are not going to get any yield, and that is not very helpful. The serial sampling will detect about 79 to 93% of the all acute myocardial infarctions. Serial sampling will detect 31 to 44% of ACS, acute coronary syndrome. The optimal timing of the enzymes, there's no consensus in them. Some people suggest that we should do at 0 hours and then 6 hours, or at 12 hours. Some people suggest that we should do at 0 hours and then 3 and 6 hours and 9 hours. So similarly, there is no consensus on the timing of the troponin. Different hospitals and different companies have their own kits and they yield it, but none of them claims that if you do a troponin, it can give you a result within 3 hours. So we come to a test which is actually promising in diagnosing the MI, the acute coronary syndrome, within that 0 to 2 to 3 hours period, which troponins and CK-MB actually miss. So here is a test which the introduction of high sensitivity Trop-T assay with lower cutoff levels for diagnosis AMI in patients with acute chest pain is associated with enhanced overall diagnostic accuracy. The gain in sensitivity may be particularly important in patients with a short duration from symptoms onset to admission. A negative high sensitivity Trop-T test has a high negative predictive value and may thus serve as an exclusionary test early in the diagnostic process. So that was, this is the test we were talking about. There's a study and an article about the high sensitivity cardiac troponin and the evaluation of possible AMI, American College of Cardiology, July 2018. It states that high sensitivity cardiac troponin assay expedites the evaluation of patients with possible acute coronary syndromes in the emergency department. It's actually a rapid rule in, rule out. They advocate serial high sensitivity Trop-T measurements at 0 hours and 2 hours to evaluate those patients with possible acute myocardial infarction and high sensitivity with high sensitivity Trop-T. Gender is important. We all know that women have a higher burden of non-obstructive coronary artery disease and plaque erosion. So their normal troponin values are lower for every assay studied. We come to, this is another latest article from the same American College of Cardiology. And it says that most patients with chest pain present to the ED to rule out myocardial infarction with very low levels of high sensitivity cardiac troponins at presentation are not changing significantly at 1 to 2 hours can be discharged from the emergency department without further cardiac testing. We've all been saying that troponin and CK-MB alone are not enough and we need to have some kind of a stress testing for patients. But here we have a test which does suggest that if we have a normal 2 tests of high sensitivity Trop-T within 3 hours, these patients can be discharged. But there is a catch here, and that is that the patients with intermediate high sensitivity Trop-T values, which I'll explain in a minute in the next slide, can have the heart or the ADAX scores utilized to assist in their disposition. So you'll see in the next slide that there is a cohort of patients where, say, this is the high sensitivity Trop-T results template, which we are moving towards. And hopefully by start of February, we will be moving towards the high sensitivity Trop-T sampling in the Marof hospital. And how does this work is that if you look at the reference range, this is up to 14 after 3 hours of symptoms. If the Trop level is up to 14 or less than 14, after 3 hours of symptoms, this will exclude acute myocardial infarction. But if it is more than 100 at any time, it clearly states that the patient is having an acute myocardial infarction or a cardiac event. So these are two very clear-cut exclusions. But there is a catch in here, and that is the area which I was alluding to in the last slide about the intermediate patients. And those are the ones where you have the result is between 14 and less than 100. Now, these are the patients which need further assessment, and they must have a repeat at 3 hours. Now, if you have repeated the sample at 3 hours, and if their initial drop was between 14 and 52, 50% rise from the initial, we need to consider acute myocardial infarction. And if their initial result was between 52 and less than 100, a 20% rise from initial, we need to consider MI. Now, if there is a patient who we did the high sensitivity Trop-T, and the rise is not up to 50% and its rise is less than 20%, then these are the patients we need to consider for differential diagnosis, and these are the patients who may need some other form of testing. And we have put here some other reasons that we need to look for. But these patients should be assessed using the heart score, which is consisting of a history, ECG, age, risk factors, and troponin levels. Now, the heart pathway simply says that if you suspect a chest pain, ACS, you calculate their heart score, and if its score is less than 4 and the serial troponin is negative, they go home. But if score is 4 and the serial troponin is negative, but still they have pain, they need to admit these patients for some kind of stress testing. So once we introduce this high sensitivity Trop-T, there will be some initial confusion in how to actually treat the patients who lie in that intermediate group. And it would be our advice that we need to move towards the site of caution, and these patients should have some kind of stress testing done. It's from the same article about from the American College of Cardiology. The prognostic ability of low-level high-sensitivity Trop-T measurements lessens the need for the use of risk scores. The use of the newer algorithms allows MI to be excluded in 3 ways. Very low levels at presentation. As I said, if they present after 3 hours and they have no low levels, so it excludes that. Low levels at presentation, but not changing significantly at 1 to 2 hours, that we said. And serial values less than or equal to 99 percentile over 3 hours. So that's another study about the incremental sensitivity for detecting acute myocardial infarction. So if we just do an ECG and rely on that, that will only detect about 26% acute myocardial infarctions. If we add the baseline markers, our detection increases to 58%. And if you add another serial ECG into that, your yield increases to 64–65%. And if you then add delta serum markers, which is doing interval studies at 2 sets of troponins, this increases to 93%. And then you add physician judgment into this as well. So that goes to 97%. But still, it doesn't go to 100%. So this is those patients, the intermediate troponin group, which neither we can rule out or nor we can rule in. So those are the patients where we may need to do some kind of nuclear testing, stress testing, or simple CT angiogram or cardiac MR or stress echo, whichever the cardiology feels better. But these are the patients who will be some patients here who would need this kind of testing to get 100% yield of the detection of AMI. So in summary, now atypical is typical, means that we need to be aware of atypical symptoms. We should always consider posterior and right-sided myocardial infarction. We need to do minimal 2 troponin high sensitivity normal values at 2 hours apart and single normal at 3 to 6 hours after symptoms onset to rule out acute myocardial infarction safely. We need to remember the elderly with different symptoms, and stress testing of some sort is mandatory in patients with intermediate high sensitivity Trop-T levels and high risk probability in heart or ED ACAS scores. Thank you very much. And if you have any questions, we can discuss this. Thank you.
Waheed, is there anyone else having a question? Can I just make a small comment, if that's all right?
Sure, please go ahead.
Thank you very much, Waheed, for your such an informative and useful clinical talk regarding a very, very common problem we face across in ER and as well as in the IPD as well. I think just to add that one of the other things which we always have to keep in mind is the pulmonary embolism as well with the chest pains. And again, they can have ECG changes, they can have slightly raised troponins, but it's one of those things which can be very, very easily missed. And again, the presentation can be, I had a patient who was sort of fairly fit with just shortness of breath for the last 1 month, and he was in his around 50s. So I think one of the other things which we all have to keep in mind is, pulmonary, pulmonary embolism, which can present almost in a similar way as like myocardial infarction.
Yes, I think, Siddharth, this is a very good observation, and obviously that falls into the differential diagnosis. And if you look at probably the slide was not very clear, in patients who doesn't have that clear-cut rise in their high sensitivity Trop-T, we have put their pulmonary embolism as a differential diagnosis for these patients. So simply meaning that these patients may have high sensitivity Trop-T rise. So we need to understand and consider pulmonary embolism as a cause as well. Dr. Omar, can you hear me?
Yes.
Omar, any comments on this?
A very good talk. First off, I'm glad that we're moving towards the high sensitivity troponin as well. It will be confusing at first for some, but I think with time they will gather everything that needs to be done And the thing that we need to always look at is, honestly, not just the lab results or diagnostic testing. I think it's obviously your clinical judgment of what the patient looks like. And I want all the medical officers and everyone else to always rely more so on your clinical judgment. If a patient comes in like that 27-year-old that you discussed at the very beginning, with the epigastric pain and the like nausea, the little bit of diaphoresis, I mean, we need to look at it clinically rather than look at labs and everything else. And then labs can help us deduce further based on our clinical suspicion whether a patient actually needs further testing, they need admission or not. But this will be a very good addition. The issue with then admitting a patient afterwards and doing stress testing is that we're unfortunately only have the ETT available here. So we don't have myocardial perfusion imaging, anything of that nature. So like a thallium or adenosine stress testing available here, which hopefully in the future we will have, which can help us further aid in treating our patients. But this is the first good step.
Thank you very much, Umar. So I presume there are no more questions. So thank you very much for everyone attending today. And we'll be launching this high sensitivity Trop-T hopefully by February, but we'll try and have some interpretation sessions before that for our juniors, especially in the IPD, ER, and ICU and CCU. So thank you very much once again.